with that, I'm going to turn it over to Tracy Wang, who's an assistant professor of medicine and cardiology at Duke University. And she's going to be talking with us about current state of antiplatelet therapy, recent results, and what they mean for my patient.
Thank you. Good afternoon. I'm very excited to be here and to see you all. This slide will present a little bit of the outline of what I'm going to talk about in the next 30 minutes. This is a pretty large territory, so I've got a lot of ground to cover. But first we're going to talk about guidelines, what's in the guidelines, evidence for effectiveness and safety of antiplatelet therapy. Then there are going to be a series of questions such as, is clopidogrel effective for everyone? What about those proton pump inhibitors that we've been hearing about for a little while now? And how do the newer antiplatelet drugs fit in? So I'm just going to go right in. As you know, acute coronary syndrome, the underlying pathophysiology is the evolution of something from a plaque that becomes unstable into something full-blown that occludes the coronary lumen. This acute thrombosis picture is first mediated by platelets, which is why antiplatelet therapies are so important. Now, given the 30 minutes, what I'm going to focus on is really the class of antiplatelet therapies known as thiazidopyridines or ADP receptor inhibitors. The primary one being clopidogrel, which is something that we've been using for the last decade or so. The first study that really established the effectiveness of clopidogrel was the CURE trial. This was published in the New England Journal of Medicine in 2001 and looked at patients with unstable anginal symptoms, both those that underwent revascularization, which at that time was either bypass or balloon angioplasty, and those without intervention, and found pretty much the same 20% relative risk reduction of cardiovascular endpoints such as cardiovascular death, recurrent MI, or stroke. So as you can see in this slide over here, on both, regardless of whether or not the patients underwent a revascularization, there was a decrease in events out to 1 year. As such, especially with more data being accumulated, this has really been incorporated well into our guidelines, both the non-ST elevation acute coronary syndrome guidelines as well as the STEMI guidelines. Here shown on this slide is the use of aspirin and clopidogrel therapy for those treated either medically without stenting, those treated with a bare metal stent, and those treated with a drug-eluting stent. And for the first two classes, aspirin is, well, for all three classes, aspirin are definitely recommended, and clopidogrel is recommended for at least 1 month, but ideally up to 1 year for patients who are either medically treated or treated with bare metal stenting. And for drug-eluting stents, because of the risk of stent thrombosis that occurs late, the recommendation right now is for clopidogrel for at least 1 year. For the STEMI guidelines, regardless again of whether or not the patient was reperfused, there is a class 1 level of evidence A recommendation for clopidogrel being used as well. So where do we go from here? Well, I think there's a few lessons learned from the data that we've collected so far. This data comes from the Action Get With the Guidelines Registry, which many of you know to be an observational registry of about 400 hospitals in the U.S. that take care of patients with acute coronary syndrome. The bars are stratified by STEMI versus non-STEMI patients. In general, for STEMI patients, we are, given the guideline recommendations, we're actually pretty good at delivering clopidogrel to our patients before they leave the hospital. So for STEMI patients, 91% of these patients are discharged home on clopidogrel. Whereas for non-STEMI, we don't do so well. About 3/4 of our patients are discharged home on clopidogrel, and 1/4, even in the absence of a particular contraindication to therapy, are still not getting guidelines appropriate care. We're doing quite well for patients who undergo PCI, which is this column over here. About more than 95% of our PCI patients are going home on clopidogrel for stent protection. But certainly less well for patients who are either medically treated or patients who underwent bypass during that index hospitalization. So what this slide tells us is, despite clopidogrel being firmly entrenched in data and within our guidelines, we still have a little bit more work to do to try to optimize antiplatelet therapy treatments for our patients. We also know that beyond patients in the hospital taking Clopidogrel, once they go home, it's very important for them to continue the therapy. And this was a study that was published several years ago that looked at patients who had a drug-eluting stent. Now, arguably, these are the patients that you really do worry the most about antiplatelet therapy because of the risk of stent thrombosis and catastrophic events after that. This study looked at about 500 patients who had an acute MI, who were treated with a drug-eluting stent, and called the patients up 1 month later to say, are you taking your Clopidogrel therapy? And it's a little frightening, but 13.6% of patients were not taking Clopidogrel at 1 month after discharge. And if you look at outcomes associated with that, in patients that do not take their Clopidogrel at 30 days, there's a 9-fold increase in mortality, 9-fold increase. So what this slide tells us is not only do we need to do a good job of getting our patients home on the appropriate therapies, we also need to be counseling them to be compliant with therapies. And John Alexander, who's following me, will give us a little bit more information about that. Why do people stop therapies after they leave the hospital? And I put this slide in there because a lot of times patients require, we're talking about using Clopidogrel for ideally up to 1 year or definitely 1 year after a drug-eluting stent. Well, sometimes patients need to undergo surgery. And the surgeon or the anesthesiologist says, well, you need to come off your antiplatelet therapy so that I can do surgery on you. And so this was a very small study that looked at patients who had a stent and who were treated with antiplatelet therapy, and found that if the patient continued on their antiplatelet therapy during surgery, they did fine in terms of MACE events, MACE being 30-day risk of MI or cardiac death. But if the patients came off their antiplatelet therapy prematurely, meaning this study was back in 2007, so back then for bare metal stents, if they came off before 30 days, for the Cypher drug-eluting stents if they came off before 3 months, and for the Taxus drug-eluting stents if they came off before 6 months, then those patients that discontinued therapy, 1/3 of those had a perioperative MACE event. Again, this is a small study, but this highlights why antiplatelet therapy is important after acute MI. And so reflecting back to the in-hospital setting when we're deciding what treatments to deliver to the patients, particularly thinking about the question of putting a drug-eluting stent versus a bare metal stent in and what the implications are from an antiplatelet standpoint, this is something we need to consider, whether or not the patient's going to require surgery within the next year. Another concern with antiplatelet therapy is the risk of bleeding. And as you can see here, across a number of different clinical trials in the red bars on the left, as well as a number of different observational registries in the green bars on the right, there is certainly a risk of bleeding that occurs when patients are treated with antiplatelet therapy. And if you contrast that to the rates of ischemic events such as death or MI, or the rates of mechanical complications such as heart failure, certainly bleeding rates are very comparable, if not higher, than the things that we usually do worry about when we think about treating with antiplatelet therapy. So bleeding is definitely a concern for us when we're picking therapies. And the degree or the severity of bleeding is important as well. And this is a study done by one of my colleagues at Duke, which graded patients according to the severity of bleeding that they developed during their acute MI hospitalization while they were being treated with medications, and found that if you bled, your long-term mortality was certainly higher. So bleeding is not just important in the acute setting, but even after the patient leaves the hospital, bleeding certainly has long-term consequences. So this is something that we need to be thinking about and balancing it against the protective benefits of antiplatelet therapies as we're choosing how to treat our patients.
So Tracy, maybe I can interrupt you. Why do you think bleeding is bad?
Well, let me get to my next slide. I'll show you. So here you go. One of the reasons why bleeding may be bad is because, well, the patient's bled, so we stop their antiplatelet therapies. These are therapies that are needed to help maintain the stent or maintain the results of whatever revascularization we give them. And so the logical thing to do when someone bleeds is to say, well, let's stop their antiplatelet therapy, see how their bleeding goes, and hopefully once their bleeding's better, we can restart that antiplatelet therapy. The problem with that is there's certainly a degree of clinical inertia here, because you can see that at discharge, patients are less likely to be treated, to be sent home after bleeding on an aspirin or a thienopyridine. And even out to 1 month and 6 months, patients are still less likely to be treated with these medications after they've had a bleeding event compared to patients who don't. So that could certainly be one reason why bleeding gives us a poor prognosis. Now, there could be other things as well, and such as, there's been a lot of debate about transfusions. Is there something about the transfusions that we're giving patients that have evil humors or something that increases morbidity and mortality? There's a lot of good platelet and biochemical evidence supporting that as well. And oftentimes the patients who are more prone to bleeding tend to be those that are sicker anyway. So that may by itself be something that biases the patient towards worse outcomes. So that was a little bit about guidelines, effectiveness, and safety. I'm going to go to the next question, which is clopidogrel effective for everyone? And I guess if I'm asking that question, then the answer must be no. And this is a study that looked at about 1,000 patients and essentially tested the platelets response after giving them a dose of clopidogrel. And what you see here is that there is a huge variation in terms of individual response to clopidogrel. Now, there could be a number of reasons why patients respond to clopidogrel differently. Some of these are clinical factors, and some of these are perhaps more intrinsic factors. So clinical factors are the things that we think about. Well, either we didn't prescribe it, or the patient didn't take it, or for some reason they were taking a dose that was not what the prescribed dose was, or we underdosed it. So those are certainly some of the clinical factors that are easily modifiable and can contribute to response variability. But some of the things that we've heard about in the news lately are the intrinsic factors, the things that a lot of research is still being done on, such as drug-drug interactions, genetic polymorphisms that make someone more susceptible or less susceptible to clopidogrel therapy, absorption issues and genetic factors that could influence the absorption of these drugs into the system, what their aggregation status was before we even started treating them. So all of these could certainly contribute to the variability in response to antiplatelet therapy. What we do know is there is a curve, a bell-shaped curve on response. If you amplify the dose, if you double the dose from a 300 milligram to a 600 milligram loading dose, for example, you can shift a lot of these patients towards becoming more responsive. And that was one of the basis for the current current study that looked at acute coronary syndrome patients, about 25,000 patients. This was actually a 2x2 factorial design, but what I've presented here is just the clopidogrel part of it. These patients were randomized to either a high dose, so 600 milligram load, 150 milligrams, so double the dose for 7 days, then the usual 75 milligram dose, versus our standard dose, which is a 300 milligram load, then 75 milligrams thereafter, and looked at outcomes. And what I want you to pay attention to first is here. If you look at the primary outcome of cardiovascular death, recurrent MI, or stroke, there was no significant difference between high-dose clopidogrel versus standard-dose clopidogrel. This was the primary endpoint of the study. What was kind of interesting, though, was if you looked at the subgroup of patients who underwent PCI. And in this group, there seems to be a suggestion that the higher dose clopidogrel was more beneficial in these patients. But we do need to recognize that this is a subgroup analysis from the study. I flipped a little too quickly, but the bleeding rates were actually fairly similar between the high dose and the standard dose clopidogrel. So if we think that if we change the dose, that might help our patients, maybe help some of our patients, the logical next question would be, well, then can we individualize our antiplatelet therapy? We've got a way of measuring what the response is to the antiplatelet therapy. Can we then titrate our therapy to that? And this is a question that we're still trying to answer right now. We now have an assay. This is the Verify Now point of care assay, which gives us a result within 10 minutes after drawing the blood. And this was a study that essentially took patients who underwent cardiac catheterization and PCI, drew their blood, and dichotomized these into two groups of patients. One who have a high platelet reactivity, meaning they're not responding so well to Clopidogrel, versus one which had a normal platelet reactivity in response to antiplatelet therapies. And what you find is that the patients who do not respond as well tend to have more cardiovascular events, such as cardiovascular death, MI, stent thrombosis, or a combination of those. Okay. So then would it make sense that we take these patients who don't respond as well and do something differently about them, such as either switching them to a higher dose or considering one of the newer antiplatelet agents that I'll get into a little bit later. And that is why we're all waiting with bated breath this particular study called Gravitas, which is doing precisely that. It's taking patients who get this test and classify them into responders versus non-responders. And for the non-responders, randomizing them into a higher dose versus a lower dose of Clopidogrel and seeing what their outcomes look like up to 1 year after this randomization. So we're hoping that this result will come out shortly. What about genetics? We certainly hear a lot about this, and this is one of the earlier studies that looked at patients who have this particular P450 polymorphism. This is a cytochrome in the liver that is critical to transforming Clopidogrel from the prodrug to an active metabolite. And this study basically found that patients who were carriers of this polymorphism, whether they're homozygote or heterozygote, tend to have worse outcomes if they carry one of these alleles. Since then, a whole slew of studies have been done, and this is a recent meta-analysis that was just published last month, going over all of these studies, again showing that if you have an allele for the 2C19 polymorphism, you had a 30% increased risk of MACE events. How commonly is this allele occurring in the population? It's about 1/3, about 28% of the population are carriers of this allele. So this is certainly not a very small minority of the population worth thinking about. And many of you have probably seen this, which was a warning put out by the FDA, a safety announcement, alerting clinicians to the fact that there are patients who are quote-unquote poor responders based on their genetic testing. And unfortunately, what the FDA doesn't say is what to do with these patients. So they just wanted to make sure that everyone knew that they were poor responders. And the text of the warning says, well, for these patients, we might need to consider other dosing or alternative agents, but does not specify. And so this is an area of a lot of research and a lot of questions right now.
So Tracy, how easy is it to test for the CYP2C19?
Well, it's not that easy, probably.
Yeah.
I think one of the great things about, let me go back. Well, let me stay at this slide then. One of the great things about the genotyping is you can pretty much perform it at any time. So, unlike the platelet function testing, where if you come in the throes of your MI, you've got platelets that are very, very active. So testing then may not be the best time. The great thing about genotyping is it's genes. So you can draw the blood at any time and test it. The problem is once you've got the blood sample in your hand, what do you do with that? And right now there are not that many places that have molecular diagnostic labs that can test it. So for most people, it's a send-out. For most institutions, it's a send-out, which could take anywhere up to a week.
How many days does that take? Yeah.
A week to 2 weeks even to come back. There are some, not quite point of care, but some sort of more cartridge-based testing that's that's hopefully going to become available in the next year or so. But we don't know how good these assays are.
So in that context, if it takes a week for most places to get it back, and you've got a patient in front of you who you're trying to make a decision about how much Clopidogrel to give, so there's two questions here.
Mm-hmm.
How tight is the association between 2C19 and Clopidogrel non-responsiveness? And if it's very tight, are most of the events occurring early, or does one have enough time to wait 7 days to get a test back to make a decision about dosing?
Okay, well, let me answer the second question first, because that's what this slide was showing. So if there was going to be some difference between the two groups, it probably is happening pretty early. Okay. The question is of how tight that association is shown in this slide. This is not presented just yet, but this is not published yet, but this was presented just in May of this year, looking at what are the predictors of a poor antiplatelet response. And while that 2C19 polymorphism is a predictor, it only accounts for 5% of the potential to be poorly responsive. And if you combine that with actually a whole bunch of clinical factors, all of those together only accounts for 12% of the variability in platelet aggregation. So I would say that no, there's not a tight association. Plus we have issues with how timely we can get these test results back. But we don't usually keep patients in the hospital for 2 weeks after an MI. So the practical implications of this is still not quite clear yet. One of the things that this presentation at EuroPCR also highlighted was that actually 20% of patients who had the allele actually had good response too, whereas 50% of the poor responders were not necessarily carriers. So there's definitely a mismatch.
So the relationship is not that tight.
Exactly. So there's definitely a mismatch between genotype and phenotype.
Yeah.
And maybe as we get smarter about all this, it may be that we require a combination of both to be able to really truly individualize therapy. But the short answer is I don't think we're quite ready just yet. Once we know that someone is a carrier, can we do anything about it? Perhaps. This is a small study, again, looking at dosing, and if we double the dose of the Clopidogrel in patients who are carriers of the polymorphism, there is evidence suggesting that we can improve their response to Clopidogrel, but no clinical outcomes yet out there yet. All right, what about those proton pump inhibitors? Well, this again, from a biochemical standpoint, we find that if patients are treated with Clopidogrel, and then you add a PPI on top, there is a decrease in the response to the Clopidogrel. And the mechanism postulated could be one of two. One is that somehow the PPI decreases the intestinal absorption of the Clopidogrel, or because the PPI works through the P450 system as well, that there could be a decrease in the activation of the Clopidogrel, or resulting in less of the active metabolite. And we've had a number of observational studies. This is just one example. That was a very large sample published by the folks at Medco, showing that if you were on Clopidogrel and you were treated with a proton pump inhibitor, you seem to have worse outcomes compared to those not treated with a proton pump inhibitor. But as you know, if you need a proton pump inhibitor, there's probably something that different about you compared to someone who doesn't need a proton pump inhibitor, and that's one of the limitations of these observational analyses that show a difference in outcomes. The FDA also chimed in here as well, and again, they put out an alert for healthcare professionals saying that concomitant use of omeprazole and Clopidogrel should be avoided because of the effect of the Clopidogrel's active metabolite and anti-clotting activity. They said that separating the doses and time will not necessarily reduce this interaction. And they said, we only know about omeprazole. We can't really say anything about the other PPIs. But so that was bulleted out in November of last year. And the reason for that last comment was because there may be a difference between omeprazole versus something like pantoprazole, which doesn't go through the P450 system. But again, the Medco folks looked at this, and the lettering is really small, but you can kind of see that most of the curves track along the same line, with actually pantoprazole being the bottommost line here, showing that pretty much all of the PPIs seem to be associated with adverse outcomes when used together with Clopidogrel. So I'm not sure that part of this may be a class effect, part of it may be drug-specific effect, depending on the mechanism that it interacts with clopidogrel.
So now, have there been any randomized trials of proton pump inhibitors in the setting of clopidogrel use?
We lucked out a little bit because there was a company that was, back about 5 years ago, the guidelines actually recommended that all patients treated with clopidogrel needed to be treated with a proton pump inhibitor to ward against some of the bleeding side effects of this therapy. So a company decided to say, well, if we need both, why don't we combine them into one pill? And that was this trial over here, the Cogent trial, where they made a combination pill of clopidogrel 75 milligrams plus omeprazole or Prilosec 20 milligrams, and randomized patients to either taking this combination pill or clopidogrel alone. And do you guys see two curves? There really actually are two curves. They're just right on top of each other because the two curves really track very close to each other, showing no significant difference in outcomes between these two curves. Now, there are a few caveats to this, though. Unfortunately, the company didn't do so well. So they wanted to enroll 4,500 patients, and they had to stop the study at 3,600, a little over 3,600 because of financial reasons. So the study was never fully completed, and we're not sure if enrolling the additional 1,000 patients would have shifted the curves apart a little bit. So this is certainly underpowered. But
pretty tight, though, aren't they?
I really like those curves. If you really wanted to, pick curves, those are two pretty close curves to look at.
And do you find it interesting that this was omeprazole, but it's the one that is specifically highlighted by the FDA as the bad actor?
It certainly is, although keep in mind this is the lowest dose of omeprazole, and we don't know if there is a dose-response effect. So if you used 40 milligrams of omeprazole or 80 milligrams sometimes in some patients, we have no idea how that would necessarily affect this. So I think this answers one piece of the puzzle. What's kind of a neat contrast here is that if you looked at GI events in this study, there was actually a clear difference. So patients who were on the PPI tended to have fewer GI symptoms. So I think probably to summarize that, I would, my philosophy has been if someone doesn't need a PPI, then take them off the PPI. But if they need it, then they need it.
And would you pick any one of the PPIs preferentially if you thought they need a PPI?
If you think that PPIs interact through those two mechanisms, then perhaps pantoprazole may be the better one simply because you eliminate one of those mechanisms. But again, we don't. That's speaking about it from a pure physiologic standpoint. The evidence has been pretty conflicted. There's some evidence showing pantoprazole is better. Others showing that pantoprazole is the same. So I think intellectually I might favor pantoprazole, but I don't have any firm evidence supporting that.
Fair enough.
The last 3 minutes I'm just going to focus on some of the new antiplatelet medications, some of which are approved and some of which aren't approved. The first one that actually is now on the market is called Prognosis. This inhibits platelet aggregation and does so in a much more potent fashion than Clopidogrel. So on the left are patients who are treated with Clopidogrel, and as you can see, there's a tremendous variation in the degree of aggregation that's inhibited by the drug. But once these patients are treated with Prognosis, then the range tightens up significantly so that there's less interpatient variability in effect on the platelets. And in the clinical trial, the Triton study was the primary study that looked at these patients with acute coronary syndrome treated with percutaneous coronary intervention. There was a 20% risk reduction when patients are treated with Prognosis compared to Clopidogrel on top of aspirin. But this is by no means a free lunch. There is bleeding. If you're going to use something more potent, then there's probably an increased risk in bleeding, and what they do see here is a 30% increase in bleeding. Look at these bleeding rates, though. We're between 1% and 2%. So I showed you bleeding rates in the observational populations of even up to 13%. So this study may or may not be truly speaking to a normal population that have the potential to bleed to antiplatelet therapies. Just tying up some loose ends with the 2C19 issues that we've been talking about, if you look at carriers of the 2C19 polymorphism treated with Clopidogrel versus treated with Prasugrel, you'll find that that among these carriers, Prasugrel still has a significant decrease in event rates. And this is briefly some, maybe, let's talk a little bit about dollars and cents here. If you think about choosing between Prasugrel versus Clopidogrel, you might save on a few things because you've got more potent antiplatelet therapies. You're less likely to require repeat PCI in the future, so that might save you a few dollars. But there's a bleeding that you're challenged with, and so patients could be having prolonged hospitalizations because of the bleeding, or come back in at a later date for bleeding and require transfusion, so that adds a few dollars. But if you sum up the net cost versus savings, there seems to be evidence that using Prasugrel could help save some money for patients and for society in general. Ticagrelor is another antiplatelet agent that is kind of going through the FDA review right now. This is another oral agent. It acts directly, so it doesn't require that activation step. It's more potent than Clopidogrel. As you can see here, this curve is the Clopidogrel curve, and these are the various doses of Ticagrelor over here. It's got a rapid onset. And the main study that studied this was Plato, which looked at non-ST elevation, acute coronary syndrome, and STEMI patients, and looked at the primary endpoint of MACE, consisting of cardiovascular death, MI, or stroke, and also showed a almost 20% risk reduction using Ticagrelor versus Clopidogrel. In fact, if you just look at one of these endpoints, one of the secondary endpoints, which is mortality alone, there seems to be a risk reduction there as well. So, good benefit. What about safety? If you look at bleeding as one of the safety endpoints, the two curves seem to track very closely together, and there was no significant difference in bleeding rates between Ticagrelor and Clopidogrel. Of note, there was a side effect of dyspnea because of probably the adenosine inhibition here, so there was a slightly higher rate of patients reporting shortness of breath with Ticagrelor versus Clopidogrel, and there's some studies going on right now to figure out exactly how clinically significant that complaint is. We talked about a few receptors on the platelet. I think 2B3 inhibitors are something that everyone's very familiar with, one of the earlier antiplatelet agents. So far today, I've been mostly talking about the ADP receptor on the platelet and how we inhibit that with these agents over here. There's actually a thrombin receptor on the platelet as well, and there have been some compounds developed to antagonize that receptor as well, one of which is a drug called the TRA drug. This has been studied in a phase 2 trial, mostly to look at dosing and safety, and found that compared to placebo, there was pretty similar risks of bleeding that obviously go up with the dosage that is used. The study was not powered at all to look for ischemic benefit, and that is certainly reflected here, but there seems to numerically be a slightly lower rate, although again the p-value was not significant, and this drug is currently undergoing 2 large-scale trials, phase 3 trials, both in acute coronary syndrome patients that are managed with PCI, as well as acute coronary syndrome patients that are managed medically. So I might have gone over a little bit of time, but just to summarize a little bit, I kind of gave you a whirlwind tour of antiplatelet therapies and how they're used in contemporary practice, as well as some of the newer agents that are coming online. But antiplatelet therapies have become and will remain a key component of anti-ischemic therapy in patients with acute coronary syndrome. And what we need to figure out is how to balance their benefit, their efficacy, against the safety profile, which is primarily the bleeding. There are some limitations to our current antiplatelet therapies, and that's why we've got this very exciting research that's going on looking at newer therapies, as well as how to modulate dosing in response to its effect. And we talk about personalized medicine. This is certainly an area where we can try to tailor the therapy that we give, the dose or the type, to how the patients respond to it. And there are also certainly drug interactions that we need to be very aware of and need to figure a little bit into how we treat and select select treatment for our patients. Thank you very much for your attention.
Thank you, Tracy. That was a terrific talk.